connecting.
Ang pagbati ay noon pa man isang karaniwan at bahagi na ng kulturang Pilipino. Buwan ng Hulyo, taong 2011, isinulong ni Congressman Bayani Fernando ang isang resolusyon na naglalayong ipalaganap ang bagong paraan ng pagbati, pagpupugay at pagbibigay galang sa kapwa Pilipino. Ito ay ang kapalit ng ating nakasanayang pagbati at pangungumusta sa pamamagitan ng paghawak ng kamay o handshake. Napatunayan na rin ng maraming eksperto sa larangan ng medisina na ang tradisyonal na kamayan ang isa sa mga dahilan na maaring maikalat ang sakit sa ibang tao at nararapat lang na palitan at sanayin ang bawat Pilipino na bumati sa pamamagitan ng Bating Filipino. Ito ang marahang at magiliw na paglagay ng kanang kamay sa dibdib at bahagyang pagyuko ng ulo sa tuwing nakakasalamuha ang ibang tao, kaibigan o katrabaho. Ang Bating Filipino Act ay muling inalayan at pinagtibay ng mga mambabatas noong Pebrero taong 2020 at sa tulong ng House Committee on Basic Education and Culture na isulong bilang alternatibo sa pagbati lalo nitong panahon ng pandemya. Bating Filipino, ang opisyal at bagong pamamaraan ng pagbati, pagbibigay galang at pagpupugay sa kapwa Pilipino na magiliw na isinasagawa sa pamamagitan ng pagsalang at pagdampi ng kanang kamay sa gitnang bahagi ng dibdib, bahagyang pagyuko ng ulo o paibabang tingin sabay ng pagbigkas ng salitang nagpapahiwatig ng pagbati, paggalang at pagpupugay. Pagkakaraan, ito'y iaangat ang ulo na nakangiti at sa mata tumingin sa taong binabati. Iniikayat natin ang bawat one na tumulong at maging bahagi sa paglaganap ng Bating Filipino. Ang Bating Filipino ay galing ng bawat Filipino.
Ako po si Bayani Fernando at yan ang Bating Filipino. Let's do this, with or without COVID.
Farmacia ni Doc is a drugstore that offers branded, generic medicines and fast-moving consumer goods. We are committed to providing Filipinos quality and value-for-money products to ensure good health, happy homes, and a secure future. Acknowledged as the world's leader in franchising, FrankCorp has completed full franchise development programs of over 3,000 businesses worldwide since 1976. Our mission. Farmacia ni Doc fulfills the dream of every Filipino aspiring to become not only entrepreneurs but valuable contributors to their community by providing its franchisees entrepreneurial support, distribution of quality pharmaceutical products, and an up-to-date adherence to regulatory standards. Believing that every Filipino deserves quality of life, Farmacia ni Doc pledges the accessibility of its wide array of products in every Farmacia ni Doc store that are quality yet affordable. Committing to its stakeholders' profit, market leadership, and growth while instilling the value of integrity in every business transaction, Farmacia ni Doc takes the responsibility of enriching the lives of the employees with an opportunity to attain their personal growth. Our vision: to be the Philippines' leading drugstore who serves the highest quality of branded, generic, and fast-moving consumer goods that sustains the health of every Filipino family. The franchise package only costs 349,000 pesos. This includes the franchise fee, point of sale's complete setup, uniforms, marketing support, training, as well as a total support system necessary to run Farmacia ni Doc. Among the benefits of owning a franchise are the following: having the right to use our trademark, name, and logo, site evaluation assistance, store design and construction assistance, documentation and business guidance, startup, pre-opening, and post-opening market assistance, extensive training on pharmacy retailing, comprehensive franchise operations manual, complete POS machine and BIR compliance, grand opening, advertising, and marketing support, continuous supply of branded, generic medicines, and fast-moving consumer goods, continuous product development, ongoing business guidance and consultations, periodic store evaluation and compliance, and business management, store operations, and customer service. Your proposed site must be within the vicinity of existing drugstores and leading drugstore chains, hospitals and medical institutions, public markets, supermarkets, groceries and convenience stores, bus, jeepney and tricycle terminals, malls and department stores, residential communities and exclusive subdivisions. Why choose Farmacia ni Doc? Because of our unique brand, commendable track record, wide range of products, and free delivery of stocks in major cities. Get your franchise now. Farmacia ni Doc. Mapagkakatiwalaan ng buong pamilya.
Hi and magandang tanghali po sa inyong lahat. Isa pong pagbating Pilipino sa atin pong lahat na naririto ngayon. Welcome to Galing ng Everyone Facebook page. Ang FB page na ito ay i-design ng Gets Pharma Philippines Incorporated upang makapaghatid sa inyo ng storya at impormasyon na naglalaman ng kabutihan, kagalingan at kahusayan ng bawat Pilipino kahit saang dako man kayo ng mundo. Ako po si Jay Ryan, a marketer from Gets Pharma Philippines Incorporated and also your host for this FB Live. The topic for today is about sugar, fats, and everything's not nice. The metabolic syndrome and its complications unlocked. This program is in partnership with Farmacia ni Doc Incorporated. To give us the welcome remarks is the representative from Farmacia ni Doc Incorporated, Ms. Juliet Pamilara.
A pleasant good afternoon, everyone. Yes, a pleasant good afternoon, everyone. Ladies and gentlemen, my name is Juliet Pamilara. I am the sales consultant of Farmacia ni Doc Head Office on behalf of my staff here. And thank you for this opportunity with our partnership with Gets Pharma rather. So welcome to KwentuJuan, Galing ng Everyone. So to all our franchisees of Farmacia ni Doc, Gets Pharma is already available to our provider, Dyna Drug Corporation. And this Galing ng Everyone is this webinar about sugar, fats, and everything not nice. It's inspire us to have an everyone's life of excellence and goodness and wellness. Okay, so welcome who are joining right now with a webinar so we can gain more knowledge about this. Thank you so much.
All right, so thank you, Miss Juliet. And wag na po natin patagalin. Let me now introduce our guest speaker for this session. Our speaker has his Doctor of Medicine and Residency in Internal Medicine Fellowship in Cardiology at the University of the Philippines, Philippine General Hospital. He is the co-author of I Am Platinum book series, first, second, and third edition. He is an active member of the Philippine Society of Hypertension and Philippine Lipid Atherosclerosis Society. Apart from his academic achievements, he is a nature lover, certified tantito, a flexitarian, a dog lover, and a dog tatay to his dog Encho. If you have an aching heart or a broken heart, you can always ask Dr. Hart. Okay, to give us lectures on sugar, fats, and everything not nice, the metabolic syndrome and its complications unlocked, let me call Dr. Hart himself, Dr. Jose Eduardo Joey Duya. Hi, Dr. Joey.
Hi! Hi everyone! Magandang hapon po sa inyong lahat. I'm Dr. Joey. I am a cardiologist and I am an internal medicine specialist, but most of all, I am a Kapampangan and I love eating and I love cooking. This afternoon, I will be telling to you a story that you don't really want to talk about. Why? Because we don't want to feel guilty. Ayaw nating nagigilty sa ating guilty pleasures, which is, in this time of pandemic, ay kumain. So allow me to share my slides. No? So this afternoon, so I hope you're seeing my slide. Okay. Does this look familiar? Ito ba ang kinain ninyo ngayong tanghali? Coming from the culinary capital of the Philippines, this is a frequent feast in every Kapampangan dinner table, no? Sisig sa umaga, tanghali, gabi, hindi kami magsasawa dyan. And I think that is not uncommon, no, sa ating lahat kasi nagiging common household item na ito. Kung hindi man yung sisig, probably ito. Namis-namis, maalat-alat, maang-anghang na adobo. Sino ba naman ang hihindi sa crispy pata na kapag yung kinagat ay pumuputok-putok pa at sa kwek-kwek na pagkasarap-sarap na isasawsaw mo pa sa manamis-namis at maanghang-anghang naman ng sauce. So I hope nagutom ko na po kayo lahat at naumay na kayo lahat because that's just my goal for this afternoon. Biro lang po, no? So my goal for this afternoon really is to talk about, no, understanding the metabolic complications of having too much of all these things, no, metabolic syndrome, focusing primarily on dyslipidemia or problems on cholesterol, no. I will be telling you about the prevalence of dyslipidemia based on our recent survey. I will be telling you an update, no, I will be telling you the stories and the update on the 2020 updated clinical practice guideline on dyslipidemia, which has just been recently uh, uh, released, no? Identify patients who are in need of appropriate therapy. Sino ba yung at high risk? At para malaman mo din, matansya-tansya mo, ano yung risk mo of having a heart problem later on in life. And then, to formulate and to join me in understanding why such therapeutic approaches are done for our patients, no? I will be telling you a simulated real-life scenario of a metabolic syndrome and how do we plan. And hopefully, you will join me in thinking of the evidence-based therapeutic management. So I hope you will answer because by just tuning in, you might just win a special prize at the end if you are answering the question that I will be posting. Hi, Ma'am Tin Kaime. Ayan. Siguro si Ma'am Tin Kaime ay nagte-test na ng mga ano niya ngayon, mga clinical chemistry niya ngayon. I will also be answering frequently asked questions, your questions at the end of the discussion. So feel free to type in your question in the chat box. Now, the case is a case of a 50-year-old female, no, Miss N.E., no, consulted me for headaches and knee pains, no. Medyo smoker po siya, hindi naman siya nanginginom, pero G2 siya, ibig sabihin 2 beses na siyang nagbuntis at may regular menstruation. Yung nanay at tatay po niya kapampangan, both of which ay naku, ang ipinamana sa kanya ay hypertension at diabetes, no. Siya po ay medyo tama lang ang timbang, no, mataas ang blood pressure sa 140/100. The rest of her physical examination are normal, no. This is the typical patients you see on a regular outpatient clinic, no. So on doing laboratory tests, we found out that the blood sugar is slightly elevated, no? Maybe not reaching the cutoff 126 for diabetes, pero nandun siya sa medyo mataas na blood sugar. The kidney is normal with a normal creatinine. The total cholesterol is elevated at 258. The triglyceride is elevated, no, at 181, not on target, and the bad cholesterol or LDL is 165, no, elevated for her age, no. The HDL is normal at 55. The liver is okay. The heart and the ECG is actually normal, and the X-ray had no significant chest X-ray findings. The patient was previously on losartan, correct dose, and was advised to lose weight through dieting and exercise. So ang tanong, will we stop on here and do we say, ay, ma'am, Miss N.E., okay na po kayo. Just continue what you are doing. But remember, this patient is symptomatic. So in summary, our patient po, no, profile ng patient, ang taong bladder niya, 47-year-old, smoker, no, 140/100, no target organ damage, no, elevated bad cholesterol, elevated fasting blood sugar. So my assessment, hypertension stage 2, that is hypertension stage 2, pre-diabetes, and dyslipidemia. The recommendations, how do we now prevent cardiovascular events in the next 10 years? Ang saya-saya, no, kung magkakaroon ka ng pasyente, wala pang sakit sa puso, may opportunity ka to intervene and to prevent seeing her in the emergency room in the next year na heart attack or stroke, no? So what do we mean by metabolic syndrome? Metabolic syndrome, let's call it METS, is a major escalating public health and clinical challenge worldwide. Why? Because we are getting urbanized. Not food supply is actually readily accessible. There's a surplus of our energy intake, and there's increasing obesity and lifestyle. Obesity and inactivity and sedentary lifestyle habits. Ang pandemic po ay hindi lang COVID ang viral. Viral din po ang mga videos ng mga nagmumukbang. Lahat po ng papanoorin mo sa YouTube at saka sa may kanya-kanya silang version ng mukbang o maramihang pagkain, no? Palakasan kumain, palakihan ng appetite, palakihan ng burger, palakihan ng pizza, paramihan ng extra rice, no? Nakakaumay pong tignan pero nakakatuwa at nakaka-amaze din. So this has actually fascinated the people, and it actually encouraged this unhealthy eating habits this time of pandemic, no? The metabolic syndrome, no? On first, five-fold increase in the risk of diabetes, no? Yung extra rice mo, hindi lang naman twice ang risk nun maging kang diabetic. 5 beses na mas mataas ang tsansa na maging diabetic ka. At yung cardiovascular disease naman, sa loob ng 5 hanggang 10 taon, maaaring dumoble ang chances mo. So paano naman nagkakaroon ng relasyon ang pagkakaroon ng paglaki ng waistline, pagtaas ng blood pressure at pagtaas ng blood sugar sa pagkakaroon mo ng problema sa kidney, sa puso, no, sa lapay at saka sa mga ugat, no? Sasagutin ho natin 'yan sa mga susunod na slide, no? Nakikita ko na po, may mga tanong na po. Maraming salamat. Pumapasok na yung mga questions. So, I'm sure you're so excited for the next slide. So, my question is, are you a metabolic syndrome patient? No? According to the International Diabetes Foundation 2006, no, kapag ikaw po ay may central obesity o yung sukat ng iyong waistline ay mahigit 36 sa males and 34 sa females. Inches po yon. No, may kaakibat po siyang computation sa centimeters. Any of the two, hindi kailangan lahat, no? Mataas ang triglyceride, more than 150, mababa ang good cholesterol or HDL, less than 40 para sa lalaki and less than 50 para sa babae. Mataas ang blood pressure, hindi kailangan super taas, kaya kailangan kahit normal, feeling normal tayo, nagba-blood pressure pa rin tayo kasi po ang 130 na systolic at ang 85 na diastolic ay papasok na sa criteria ng metabolic syndrome. At kung mataas-taas ang iyong blood sugar, more than 100, dalawa dito plus abdominal obesity or yung tinatawag nating love handles, no, or a body mass index of more than 30, ito po ay mako-consider na metabolic syndrome. So this is just to show you by illustration the risk factors, no, that make up metabolic syndrome. If you're going to look at the Framingham Cardiac Risk Assessment tool that we use, makikita mo na age is not modifiable, no? Habang tumatanda ka, bumabagal ang metabolismo, no? Hindi natin nababago 'yan. But there are factors that we can change, such as our total intake of cholesterol, our bad cholesterol, no, being a smoker and abstaining from smoking, or if you're smoking right now, stopping smoking, and your blood pressure control and your diabetic control can be modified. Although at a certain degree, diabetes is genetically determined, ibig sabihin kung meron kang magulang o mga kamag-anak na may diabetes, mas mataas yung chances na magkaroon ka ng diabetes. So the more that you have to be conscious not to get diabetes. No. So how do we now unlock the mystery of metabolic syndrome? When I first became an internist and a cardiologist, I was quite puzzled how are these interrelated. Para kasing on one point of view, parang wala naman silang relationship sa isa't isa. But I hope by this lecture, magkakaroon tayo ng konting kalinawan, if not fully understand it. So, metabolic syndrome, syndrome X unlocks. It begins with adding your fats, no, or begins with insulin resistance, because with increased visceral adiposity, ito po yung taba na naiipon sa ating mga tiyan, yung tinatawag nilang beer belly, kung saan ang taba ay nagpopondo sa ating mga internal organs, ito po ay nagki-create ng maraming hormonal changes such as yung tumor necrosis factor alpha at interleukin-6. Ito po ay mga hormones or mga substances na nagpapadami ng ating inflammatory cells or inflammation. Ito po ay nakakapagpalapot ng dugo at both of which ay nakakapag-cause ng dysfunction or abnormal na pag-function ng ating mga ugat. No? Sumisikip po sila at sila po ay nagkakaroon ng mataas na resistance sa blood flow. So therefore, tumataas ang blood pressure. No? Ito pong free fatty acid na product ng ating mga taba kapag sila'y natunaw ay pupunta sa liver, no, at magkukos ng fatty liver. Yung fatty liver naman na punong-puno ng taba, tataas ang production niya ng asukal kasi maliban doon sa kinakain mo sorry po, nabulunan ako. Maliban doon sa asukal na kinakain mo, yung ating liver ay gumagawa din ng sarili nating asukal, no? And dahil po sa free fatty acid at sa inflammation, nagkakaroon ngayon ng insulin resistance. Kahit may insulin tayo, hindi masyadong tumatalab ang insulin at hindi masyadong naa-absorb ang sugar sa ating mga muscles. Sa kabilang banda, anong ginagawa ng inflammation sa ating taba, no? Tumataas ang ating triglyceride, no? Naiipon siya bilang 3 fatty acid at 1 glycerol molecule, bumababa ang ating good cholesterol at nagkakaroon tayo ng maraming small but terrible na bad cholesterol na ang tawag ay LDL. Titingnan naman natin ang epekto niya po sa pancreas. Ang pagkakaroon ng matabang katawan ay nagkakaroon ng paghina ng ating mga insulin secreting cells, no? Nagkakaroon po tayo ng predisposition to develop type 2 diabetes or your tinatawag nating high sugar or high diabetes, no, diabetes sa sinasabi ng ating mga pasyente, no. Sa mga muscle naman, nagkakaroon po ng resistance or hindi pagresponde ng muscle doon sa insulin kaya hindi na ipapasok po ang sugar papunta sa mga muscle. So kapag po ang sugar ay kalat-kalat sa ating mga ugat, mataas po ang tsansa na magdeposito po ito sa ating ugat. Kapag po ang fat ay kalat-kalat, no, ay dumadaloy sa ating mga ugat, tumataas po ang tsansa na magdeposito siya at magbara ang ating ugat sa kalaunan. So ang insulin resistance po ay ang common denominator or ang common factor ng labis na pagtaba, pagtanda ng mas maaga, ng pagkakaroon ng pagbabara ng ugat, pagtaas ng blood pressure, pagtaas ng sugar, pagtaas ng cholesterol, at ito ay nawo-worsen o ito ay napapalubha kung tayo ay laging nakaupo, nanonood ng Netflix, nanonood ng YouTube, at nakikinig sa lecture na ito. So, I hope after this lecture, tatayo po tayo at mag-exercise tayo mamayang hapon. So, your reactive oxygen species, no, are made in metabolic syndrome, and it's actually, no, also caused and propagated, pinaparami po siya ng pagkain nating napakatamis, no, ng mataas nating insulin, ng pagkain natin ng matataba, at ang pagkakaroon natin ng stress, no, inflammatory. When you have infection, you have a lot of inflammatory cytokines, and it's all contributory to the development of metabolic syndrome. This metabolic syndrome actually makes you at risk to all this problem: heart disease, lipid problems, no, hypertension, diabetes, no, dementia o yung pagiging makakalimutin, no, cancer, polycystic ovarian syndrome, ang mga hormonal imbalance sa babae na nahihirapang magbuntis, no, at pagkakaroon ng non-alcoholic fatty liver disease. So pag-usapan po natin mas detalyado ng konti, ano ba talaga yung bad cholesterol? Alin ba doon yung bad? Yung H ba o yung LDL? No? Ano naman ang kinalaman ng triglyceride? Pag ba okay na ang bad cholesterol ko, kebs na sa triglyceride, pakialam ko naman doon sa VLDL. O, diba? Yung LDL ba, lechon de leche? Oh, 'di ba? So ano ngayon ang lipoprotein? Ang lipoprotein po ay isang structure na nagko-contain ng protina at taba, no, in various proportions. So ito po yung sangkap ng ating proportion. Ang sabi po ni Ma'am Maureen, galaw-galaw daw tayo, guys, baka tayo ma-stroke. Okay. So Uh, what makes it this exciting? Para mas maintindihan nyo, ang chylomicron po ay 99% triglyceride, no? Ang VLDL, no, or your very low density lipoprotein is 90% fat, no? Mostly triglyceride with lesser amounts of cholesterol. Ito po yung kapag po natulog ang mantika, makikita mo yung mantika, 'di ba, natutulog, nagsisebo. Napakahirap gisingin ng natutulog na mantika, no? Ganun din po sa mga ugat natin. Kapag po yung taba po natin ay nandun na sa ugat, napakahirap po nitong tunawin. Your LDL, on the other hand, is the major, one of the major key player, if not the major, no? Ito po yung major carrier ng ating cholesterol sa ating dugo. At kalahati ho nito ay cholesterol ester or nakaimbak na cholesterol and free cholesterol, no? Ready to be used by the body, no? High density lipoprotein or HDL, I call it heavenly cholesterol, no? Kasi ito po ay may equal amount ng proteins and lipids at ang primarily function po niya ay kunin ang mga bad cholesterol na nakadeposito sa mga ugat at dalhin siya sa liver para tunawin, para magamit siya ng ating katawan. So we're talking about cholesterol. Pangit ba ang cholesterol sa katawan? It is not bad. Cholesterol on the correct amount is actually useful for the maintenance and the development of the body. Cholesterol po ang papakintab ng iyong balat, ang nagpapaduwi ng iyong skin, ang nagme-maintain ng integrity ng iyong mga cells, no? So day in and day out, meron tayong tinatawag na turnover ng ating mga cells. Namamatay sila at kailangan natin gumawa ng bagong cells. And because of that, no, kailangan natin ng panibagong set of cholesterol, but not too much, no? And not the bad type of cholesterol. So if you're going to look at it, kung ihilera natin sila, kung ito ay blatter sa presinto, si LDL, IDL, and LDL, VLDL, at chylomicron, they belong to the bad guys. Ito po yung pinapablatter natin. At yung HDL, ito po yung ating lifeline kasi siya ang tagalinis ng ating mga cholesterol sa katawan, no? If we're going to look at it on a graphical point of view, you will see here on yellow are your LDL cholesterols, no? Once they get inside your blood vessel wall, no, in between your cells, no, pumupunta po sila doon sa ilalim ng ating mga cells at sila ay nag-undergo ng oxidation, no? Kumbaga, chill lang sila dyan, tatambay lang sila dyan, at sila ay tumambay dyan, magtatawag sila ng neutrophils, no? Yung mga neutrophils, sila po yung naglilinis ng cholesterol. Pag kinain ng neutrophil yung mga cholesterol, magkikreate siya po ng signal. Nakikita po ninyo ito para mga bubbles. These are cytokines, no? These are inflammatory cytokines na magtatawag ng mas maraming cells para linisin yung fats na nasa ilalim ng ating mga ugat, no? Sa kalaunan, no, sa kadamihan ng cholesterol, sila po ay patuloy na lalaki hanggang sa dumating yung pagkakataon na sila po ay puputok na at sabay-sabay na marirelease ang taba na naipon nila sa ating mga ugat, no? Ito po yung tinatawag na atherosclerosis, which is the proseso ng unti-unting pagdedeposito ng taba sa ating mga ugat. So what? Kung may atherosclerosis tayo, mahaba naman ang buhay. Hindi ko naman yan iindahin kasi bata pa ako. I'd like to remind you that as early as your second decade of life, you are already depositing cholesterols on your blood vessels, on our blood vessels. Nakikita po natin yung progression dito ng isang atherosclerotic plaque at padami ng padami yung fat content nito until such a time na mapupuno siya beyond the limits na kayang i-sustain or i-contain ng ating plaque at puputok siya at magkukos siya ng maraming problem. This diagram will tell you that from the second to the third decade of life, basically wala pa tayong nakikitang problema. It's clinically silent. So as we talk right now, yung kinain natin kaninang barbecue, yung kinain ko kaninang lumpiang Shanghai, yung kinain nyo kaninang sisig with extra rice, ay unti-unti nang naidideposit sa inyong mga ugat, no? Basically, sa stage po na ito, ang growth ng ating mga plaque ay basically pa-deposit lang siya ng pa-deposit. Pagdating mo ng third to the fourth decade, paglipat mo, nagkakaroon na ng increase in smooth muscle and collagen increase. At Pagdating mo po ng 4th to the 5th decade, doon na yung nagkakaroon na ng pagbabara ng mga ugat, no? And pwede pa rin siyang manatiling silent, or kung in the presence of multiple iba-ibang risk factor, pwede na siyang maging heart attack or stroke. But that does not discount the fact that you can still have a heart attack early on in life. If you had inherited a genetic predisposition na mana mo yung genes ng mataas na cholesterol mula bata ka at ito ay evidence sa iyong pamilya, maaaring mapaaga or ma-fast track, no? Ma-fast forward ang mga pangyayaring ito, no? Next, gaano ba kalaki ang problema? Hindi ba COVID ang problema natin? Bakit pinag-uusapan ni Dr. Duya, sorry na-internalize ko na yung moniker na tinawag sa akin. Bakit ba problema natin ang puso? Well, dapat naman talaga siyang pinoproblema, di ba? Pero bakit natin pinoproblema ang sakit sa puso? Why? Because it still remains to be the top cause of mortality in the Philippines. If you look at our census, diseases of the heart and of the vascular system are top cause of mortality, no? Hindi pa po natin diyan binibilang yung number of heartbroken dito sa Pilipinas, pero yung namatay po sa sakit sa puso at namatay mula sa heart attack, stroke at mga baradong ugat, madami po, no? Mas madami po ng hindi hamak kesa doon sa mga namamatay sa COVID. So that's why we need to be vigilant while we wash our hands, while we keep social distance, and while we stay at home. We should also make ourselves healthy by actually, no, trying to learn all these things, no? The 2015 guideline was published in 2015, and the 2020, although wala pa po siyang fine print, ibig sabihin hindi pa siya officially napapublish, has been released already at the convention of the Philippine College of Physicians and the Philippine Heart Association. And I had the privilege of asking Dr. Cecil Jimeno, which is my mentor in UPPGH, who's also part of the technical writing group of the Philippine Philippine Dyslipidemia guideline, and the blessings also of Dr. Luella Santos, the head of the technical group. I was able to get some of the slides that I will be sharing with you, so as to cascade the information to the public, no? This is a metabolic syndrome profiling of the general population done way back in 2008. And as we can see here, no, if you are about 30 to 39 years old, no, probably 15, 16 sa 100. Presently po, meron na tayong 228 people. So sa 228, mga 30 po sa atin ang may metabolic syndrome. Aray, busi-busi na, baka may masagasaan. Sorry po sa masasagasaan ko kasi I myself have risk factors for developing of metabolic syndrome, no? But when you are 50 to 59 years old, 37 sa bawat 100 ang probably may metabolic syndrome. That was way back in 2008, no? 15%, 25%, 37%. Sila po, itong ganito kadami, yung probably nagkaroon ng sakit by 2018. If this is true, we have to find out, no? The only way to see is when you see them in the clinic, no? If you were going to look at blood pressure, parang across both males and females, halos parehas lang. Pero of course, mas mataas yung blood pressure sa lalaki. Usually, mas maraming hypertensive na lalaki. But waist circumference, mind you girls, no? Mas madami ang babaeng mas malaki ang waistline, no? Kaway-kaway ang may mga dad bod dyan, no? So PM po ang may mga dad bods, no? Triglyceride, mas madaming lalaki ang mataas ang triglyceride content, no? But in terms of good cholesterol, mas madami ang babaeng mababa ang good cholesterol. And mind you, when I first saw this data, I've realized that there are a lot of Filipinos that basically are below the target good cholesterol. So how large is the CV risk, no? In terms of projecting it, no, in that particular study, if you have metabolic syndrome, the chances of getting a heart attack is about 1.5 times in the next 10 years. And the chances of getting diabetes, you will not guess it, 16 times more likely. If you are metabolic syndrome today, in the next 10 years, 16 of you will become or will probably be diabetic. So therefore, how do we now reduce that risk? Alam na natin kung gaano kalaki yung risk, no? Throughout the years, tumataas po yung ating level ng cholesterol as a nation, no? So, while we try our best to look slim and fit, internally, we are still getting fat, no? So that's a sad reality. No, if you're going to look at this study, about 46% of Filipinos, no, have a high total cholesterol of more than 240. So that's a wake-up call. Did you ever get your full lipid profile this year? So siguro it's about time to get it in time for the holiday season. Bago po pa kayo magmukbang sa Noche Buena, bago kayo mag-unli barbecue, no? Kailangan siguro mas maganda magpalipid profile po tayo. Sabi po ni Ma'am Maureen, ingat-ingat daw tayo sa mga kinakain natin. Huwag natin siyang gagawing pampalipas ng oras. Tama po yan, no? Kasi ngayon ang hobby natin, aside from surfing the internet, is seafood diet. When I see food, I eat it. Wala nang isip-isip pa. Okay, about borderline cholesterol, about 38%, no? What about naman low HDL? 70% in general. 7 in 10 Filipinos have low cholesterol. And in general, ang may high cholesterol, which is the LDL. Ma'am Cecil Jimeno usually tell us in lipid lectures, LDL stands for lechon de leche. So it's the type of cholesterol that is bad. So do not take too much lechon whenever you go to a birthday party or whenever you go to a fiesta, because it will actually pile up into your internal organs if you will not be able to burn it, no? So the scope of the guidelines. So aside from non-pharmacologic advice, should we start a patient on lipid lowering drug, no? So siguro po ito madaling sagutin. Masagot dito ay yes, no? So the question is, ano yung gagawin natin, no? What are the advice that we should do to these patients, no? A lot of our attendees are pharmacy assistant and pharmacists. So pag bumili po ang mga pasyente natin ng mga gamot sa hypertension, gamot sa diabetes, gamot sa mataas na cholesterol, i-advise na po natin sila na kailangan ang diet, no? The treatment of metabolic syndrome does not start with taking the medications. No, it's just a part of it. No, it is actually not taking in a low fat, low cholesterol diet rich in fruits and vegetable that is recommended. On what proportion? No, always and always nire-remind namin, the Pinggang Pinoy strategy ay ang diet na fit sa Filipino. It's not the mukbang diet. It's not the South Beach diet. Na, ano pa ba yun? It's not the intermittent fasting or ketogenic diet that is recommended. No, the DOH, FNRI, and all the specialty societies are harping on Pinggang Pinoy, which means that, no, it's a 9-inch plate method, no? Ganun lang po dapat ang laki ng ating plato at dinidistribute natin siya among the food groups about 1,500 calories per day, no? Depende po sa iyong level ng physical activity. Half of the plate is leafy green and 1 serving of fruit per meal. So yes po, you heard it right. Hindi po bawal sa diabetes ang magprutas. Ang bawal po yung sobra-sobrang dami ng prutas. For example po, mansanas, kalahating mansanas, no? Isang maliit na pongkan, no? 9 hanggang 10 piraso ng grapes, no? Or ubas, pwede po siya, no? Pwede kayong kumain ng fruit as long as in moderation, no? 4 to 5 servings of fruit per day is allowed, no? Yung rice po, ina-highlight ko po, 1/4 lang. Hindi 3/4. Kanin, tapos yung ulam, nagta-diet ako, konting ulam na lang at saka konting gulay na lang. Pero yung kanin, I cannot let go of it, no? Wag po siyang parang heartbroken, ex mo na nag-heartbreak sa'yo, hindi maka-let go. Dapat we can let go of the rice pag hindi naman talaga tayo gutom at hindi naman talaga siya kinakailangan. So this is just to show you kung ano yung mga pwedeng kainin. 4 slices of loaf bread, or isang cup ng spaghetti or isang cup ng sopas, no? 1 piece of root crop, kapalit ho yan ng kanin. Hindi po yan kasama ng kanin. Pero typical Pilipino, no? Nakipamiesta ka, kumain ka ng kanin, may pansit, may spaghetti, kinain mo lahat kasi nahihiya ka, baka sabihin, ang choosy-choosy mo, no? Hindi po kinakailangan. Choose, sabi nga nila, if you're going to choose between two evils, choose the lesser evil, no? So 2 servings of any of the following. Pwedeng fish, pwedeng 1 piece of chicken, pwedeng 1 matchbox size of meat, 1 piece of small chicken or chicken egg, no? Wag yung sobra-sobra, no? So that's basically it. If you would like to learn more about Pinggang Pinoy, there are beautiful infographics at the site of the DOH FNRI. You will enjoy looking at the way they actually made sample plates for every meal for every Filipino of every sizes of every age, no? Smoking. Alam mo na yan. Alam na natin yan. Ang cigarette smoking is never good for any part of your body, particularly for the heart and the lungs. So, this 2020-15 guideline recommendation is carried in the 2020 guideline recommendation. So, the 2020 guideline recommendation is strongly recommending cessation in all forms, either cigarette smoking, vaping, or real-life cigarette smoking, because of the paucity of long-term studies on e-cigarettes, kasi bago lang po siya, no? Ang ano po ay recommended lang ang pagtigil, no? Pero hindi po ito nangangahulugan na mas okay po at mas less harmful ang e-cigarette, no? Because hindi pa po natin nara-reach yung ganun kadaming pasyente na nagkakaroon ng complication kasi bago pa lang siya. As you know, yung yung hinit-hit mo ngayon, yung ninosi mo ngayon na hindi mo naman ikakamatay ngayon. Probably ikaka-cancer mo yan in the next few years, or ikakaroon mo ng heart attack or ikaka-stroke mo yan in the next few years. But as early as now, we are strong in recommending that it should be stopped, no? Because it increases your blood pressure, it increases your oxidative stress. In fact, it increases your risk of heart attack by almost 2 times, no? So therefore, the Technical Review Committee recommended to stop e-cigarette and stop smoking in all forms. What about exercise? Ito yung ating ito yung bagay na lagi nating iniiwasan maliban kay Judith. Yung sa due date ng ating bayarin. Exercise. Pag pinag-usapan mo na yung exercise or kapag meron ng exercise video na nakita mo sa Facebook, iso-scroll up mo na yan no? Minsan hindi tayo interesado. But the recommendation is adequate exercise for all, no? Because it has been shown na yung number needed to treat or yung NNT ay napakaliit po, no? You just need 48 people to exercise before you can prevent a cardiovascular event. And for you to prevent a heart attack, if 7 people are exercising, one of you or one of us will prevent a non-fatal heart attack. No, ganun ka-importante at kaganda yung exercise. And now we understand more than ever that we have more solid proof why we need to exercise despite the pandemic, and we have to be creative on how to keep moving despite the social restrictions, no? So exercise has marginally decrease your LDL, triglyceride, and increase your good cholesterol. The recommendation po, hindi naman ganun kadami, 150 minutes po in 1 week. So if you're gonna divide 150 by 7, no, it's not that bad, no? About 20 minutes to 30 minutes of exercise per day, okay na po yon, no? So by walking the stairs, no, or climbing up the stairs, by walking into your garden, by walking the stairs, climbing the stairs rather than taking the elevator, these are just simple things, no, na pwede mong gawin. Or just by standing up, sitting up on your desk, even if you're doing online work or online study, pwede po natin gawin yan. Me, I am actually allotting 1 hour of my time every day to start my day, despite how busy and toxic I am, to walk. Sometimes 30 minutes, but when I can, I do exercise a lot of time. So among those of us na non-diabetic, wala pa po tayong sakit sa puso, pero tayo po ay meron ng risk factors na nabanggit. Makakatulong ba kung magsa-statin therapy ka na? So, anong sinasabi ng ating mga experts? Kung ikaw po ay lalaki, or babaeng tapos nang mag-menstruate, ikaw ay smoker, ikaw ay hypertensive, may katabaan, may history ng biglaang pagkamatay sa pamilya, no? For cardiac death, ikaw po ay may urinalysis na may protina, no? Ikaw po ay may lumalaking puso sa examination ng doktor or sa ECG or X-ray, dalawa po, no? Kapag po ikaw ay more than 45 years old na with an LDL of more than 30, no? Pwede ka pong bigyan ng statin para makaiwas ka sa sakit sa puso sa kalalaunan. Particular attention po for those na may history ng familial na hypercholesterolemia, yung may mga strong ang family history, magbe-benefit po sila. Sila po ang unang statin benefit group na magbe-benefit or kuha ng benepisyo sa pag-uumpisa ng statins, no, sa mas maagang panahon. Ito pong mga pasyenteng ito, sila po yung may namatay ng maaga, napakataas ng cholesterol, more than 190 bad cholesterol, no? So, meron po tayong criteria na sinusunod na kung saan madadiagnose ka ng familial hypercholesterolemia. Okay. For those na diabetic without evidence of atherosclerosis, statins are recommended, no? So kahit na po, no, pag ikaw ay diabetic, kahit wala ka pang sakit sa puso, dapat po daw na tayo na ay mag-statin. Bakit, no? Tingnan po natin, balik tayo dun sa kaso natin. Yung pasyente natin, may HbA1c na napakataas, no? Ito po yung marker ng cholesterol ay sugar mo in the past 3 months. Triglyceride po ay mataas, no? Despite the fact na naka-metformin na siya. The bad cholesterol is still not on target, no? And the good cholesterol is still not on target, less than 50. Pero may mataas na po siya na liver function mula sa fatty liver disease. So this patient, we started on a statin despite the elevated liver function test. Ito po ay karaniwan nating nakikita, no? Hindi lang namin mga doktor, even sa mga pharmacist, tinatanong po ito, hindi po ba ako magkakaroon ng liver failure? Mataas na nga yung ALT, AST ko, pinapatuloy pa rin ni Dr. Duya yung aking simvastatin, rosuvastatin, atorvastatin, or what have you, no? Bigyan nyo na lang po ako ng fibrate. Bigyan nyo na lang po ako ng omega fatty acid. Tama po ba ito, no? So, letter A ang sabi ni Ma'am Liz or Denisa. Tama po, Ma'am Liz. Tama. We should still start this patient on statin. Maraming salamat po sa pag-comment. Because in diabetic, even without evidence of atherosclerosis, statins are recommended for primary prevention. Wala pang sakit sa puso, pwede mo nang bigyan. Why? Because, no, as we have been seeing it, mababa po yung number needed to treat, no? A 100 lang po, mape-prevent mo na ang fatal and non-fatal MI. 200 na tagagamutin mo, isang stroke ang maiiwasan. Sa 45 na gagamutin mo, pinagsama-sama po ito, no? Makaka-prevent ka ng isang event. At yung angioplasty or bypass, makaka-prevent ka sa 200 na gagamutin mo. Therefore, ang pag-umpisa ng statin ay ang iyong maliit na pag-iipon para makaiwas ng pagpapa-bypass or pagpapa-angioplasty later on. So I'm very happy with all your responses. Lahat kayo will start on statin. So yes or A to statin. Yay! Thank you very much po, Ma'am RJ Sasa, Marcelina, Emeline, and Maymay Balboa. Next, in patients without atherosclerotic artery disease, statin should be recommended. Why? Because it has been shown in studies that in newly diagnosed diabetic patients, such as this study in the Philippine Journal of Internal Medicine, on first glance, no, sila po ay meron na agad peripheral neuropathy, nephropathy, at retinopathy, no? And their ECGs ay meron ng signs of ischemia or pagbabarang ugat, may signs na ng old heart attack, may signs na ng paglaki ng puso, and even irregular heart rhythm. So sa pagkakadiagnose pa lang po, sa unang beses na makikita mo siya, if you're going to explore the laboratories, you will see already target organ damage. So ano pang inihintay natin? Mag-aantay pa ba tayo ng lipid profile? Hindi na. If your patient is diagnosed diabetes with other risk factors, no, or just the plain diabetes, there's benefit in statins with the goal of reducing it to less than 30% LDL or less than 70. The magic number is less than 70 for high-risk patient. And as you will see later on in the new guideline, less than 55 for very high-risk patient. No, your patient is already on statin. Next frequently asked question, Doc, ano ang pagkakaiba ng fibrate sa statin? Pag ba ikaw ay naka-statin, hindi ko na kailangan ng fenofibrate or gemfibrozil. No? In patients who's diabetic without ASCVD, fibrates are not recommended as alternatives to statin therapy because we should give and protect all these patients from cardiovascular endpoints. The benefit or the evidence on statin is overwhelming that it actually mandates us to put all diabetic patients on statins on various doses, on various potency, depending on the maximally tolerated dose. Ibig sabihin po, hanggang kayang i-push yung mataas na dosage of statin, the better, as long as walang side effect at minomonitor yung liver and kidney function. Because on the long run, the overall benefit of statin is greater than just the short-term outcomes. No, therefore, we are not just after the numbers. No, we are after the long term. Hindi mamamatay, hindi mapuputulan ng kamay, mananatiling naglalakad at hindi biglang babawian ng buhay. Yun po ang importante sa isang cardiologist, sa isang internist, endocrinologist, or lahat ng mga doktor mo na nag-aalaga ng iyong mga internal organs. So in this patient, pagbalik po niya, yung 2D echo po niya, nakita na may malaki na siyang puso, no? Ang treadmill exercise test po niya ay nag-positive for signs of pagbabara ng ugat sa puso, no? Yung ating mga gamot, naka-fenofibrate po siya. Sorry po for this typographical error. It's supposed to be 160. Simvastatin 20. Yung losartan was shifted to a dual antihypertensive. Yung kanyang metformin at glimepiride, nistartan siya ng doktor niya at nagkaroon siya ng aspirin and metoprolol. She was advised to undergo coronary angiography but she refused. So for those patients na hindi kayang ma-afford, walang pera, no, walang kakayahan, or nasa parte ng Pilipinas na hindi readily available yung technology ng coronary angiogram, angioplasty, or bypass, ano yung ginagawa namin, no? So therefore, we are achieving the targets as tightly and as promptly sa lalong madaling panahon because this will reduce the chances that this patient will have a heart attack. Next po, no? Ano po ang ibibigay natin? I think this is a question for our pharmacist and pharmacy assistant. Ano ang nakikita po ninyong ibinibigay ng mga doktor? Pravastatin 30, no? Simvastatin 20. Letter C, simvastatin plus fenofibrate. Ang bilis-bilis naman sumagot ni Ma'am Taj Majil. Okay? At torvastatin. Very good po. Letter D. Very good din si Ma'am Liz or Denise. Napakabilis po ng kamay nila. No? Hindi po kumupit pero tumipe sa inyong mga keyboard. Mga keyboard warriors po sila. Pati si Ma'am Aurea Moril Bayangos. No? So, letter D. For individuals with acute coronary syndrome or stroke or those with established coronary artery disease, statin therapy is recommended and should be continued when already on statin and should be intensified as needed. No? So which statins are actually useful for patients with established atherosclerotic cardiovascular disease? No? We should actually go aim for this categorization, no? Kung we will decide kung low intensity, moderate intensity, high intensity. So we're talking about the general population. So if you're a general population, less than 2 risk factors, matanda ka lang, di naman mataas masyado yung cholesterol mo, halos nasa more than 130 lang, wala ka namang ibang risk factors, you can do good on low intensity. The goal of reducing it by 20 to 30% LDL cholesterol using Fluva, Prava, and Simvastatin on these doses. But if you have more than 2 risk factors, no, particularly if you're diabetic, no, you are going to get moderate intensity statin, no? Ito po yung options: atorvastatin, fluvastatin 80, atorvastatin 10, rosuvastatin 5 and 10, and simvastatin 20 to 40. No?
It's 3
Mind you,
o'clock.
kapag po tinaas natin yung ating statin, for example, by putting simvastatin 80, I'm seeing a lot of patients going to me on simvastatin 80, tapos lambot na, hindi na halos makapagsuot ng salawal, hindi na halos makapagtanggal ng polo shirt, kasi ang sakit-sakit at ang hina-hina ng muscle because they're already having symptoms of or side effects, no, from your high intensity statin. By doubling the dose of your moderate intensity does not mean doubling the effect, no? Because it only increases the risk of side effects if you double the dose. In fact, pharmacologist says that by doubling the dose, you just increase the efficacy by only 7%. But with the risk of, or with the trouble of actually increasing the side effects. So what are you going to do? If your patient is high intensity, no, is high risk, meaning to say, post-cardiac heart attack na, no, or post-bypass na, post-angioplasty na, nagjo-chest pain pa din, mataas pa rin yung lipids niya, you opt for the more potent statins, which are atorvastatin and rosuvastatin. No? So this talk is not meant to actually glorify atorvastatin or rosuvastatin, pero may personal bias po ako dahil halos lahat ng nakikita kong pasyente ay nandun na sa moderate intensity to high intensity category na, no? So in general, no, 30% decrease in your LDL cholesterol for the general public. For those who cannot reach the goal because of familial hypercholesterolemia sila, 50% reduction from the baseline. Kung dating 200, bababa mo ng 100, okay na yon. But kung dating 700, bababa mo ng less than 350, okay na rin yon. Kasi probably, if you have familial hypercholesterolemia, you'll not ever make it to less than 55. No? So, the goal of lipids in ACS. So in ACS, already on statins, no? Mataas pa rin yung lipids. What can you do? You can add on a drug called ezetimibe because this will further reduce your LDL cholesterol, no? So, there's their benefit of adding fibrates, no? For those patients already on statin, no? Huwag mong nililipat sa fibrate. The benefit of fibrate siguro would be on those patients who are already on maximally tolerated statin, but you're still not able to reach your triglyceride goal of less than 150. And that's only the time we add on. I repeat, add on and not replace statins with fibrates, no? So among those naman with diabetes, kailangan mo pa ba talagang mag-lipid profile given that no, may benefit pala ang statin? Why not do statin for all, no? Among those without ASCVD but with multiple risk factors, do we need to do a lipid profile? The lipid profile determination is always useful. Why? In what setting, no? For individuals, kapag meron na siya sakit sa puso or may diabetes, magagamit mo ang lipid profile sa pag-monitor kung yung pasyente mo ay on target. Because nakikita natin sa mga long-term studies that if you keep these patients on these target levels of less than 55 for high risk, less than 70 for very high risk, for less than 70 for high risk, and less than 100 for intermediate risk, the long-term outcomes are actually very great, no? For those without sakit pa, more than 45 with 2 more risk factors, screening. Meaning to say, wala pang sakit. Isi-screen mo lang, titignan mo lang kung magbe-benefit siya. It is also recommended. And for those even on statin, para mo ma-adjust yung dose at para mo ma-monitor yung treatment response niya, monitoring it every 8 weeks to 12 weeks will actually be useful. So yung pong mga pasyente, hindi namin pinapa-repeat profile after 1 week because hindi pa enough yung time para maayos yung metabolic imbalance because usually by convention, we repeat it by a quarterly or every 3 months or as quick as 6 to 8 weeks for your high potency statins, no? So, kung look at it, no, after lifestyle modification has been advised, if there is a presence of diabetes or established ASCVD, we go statin. And this statin, we give it for life as long as feasible, no? As long as tolerated with monitoring, periodic monitoring of the lipid profile. Pag more than 45 and 2 risk factors, no, wala siyang sakit sa puso, no, di lifestyle modification lang. Pero pag meron siya or may diabetes, we proceed with the lipid profile, and we proceed with the statin treatment. And then, this is one thing, no? For our family members, no? I'm sure meron kayo at may kakilala kayo na merong dyslipidemia or merong risk factors. The monitoring is done every 6 to 8 weeks. Okay. Next, we actually deal with the other portions of the high-risk group. In patients with established ASCVD, of course, sila pa ba ang hindi magkakaroon ng statin therapy, no? In this patient, after being on high-dose statin, the patient developed muscle aches and cramps on the shoulders and the hips, upper arms and thighs. And the patient developed thick-colored urine. So we are already considering possible rhabdomyolysis kasi may T-color urine siya at may muscle symptoms siya. The creatinine was elevated, no? But the total cholesterol, triglyceride, the LDL, and the HDL were almost normal. And the HbA1c was not on target but is fairly reduced as opposed to the 11 that is the presenting. But if we're going to look at the muscle enzymes, no, the CKMM, which is an enzyme that actually elevates in muscle injury, no, and the total CKs are actually elevated, confirming the diagnosis of a side effect of your statin. So for this particular dose, for this particular patient, guys, nandito na po tayo. Our friends from GX are actually from friends from Gets are actually tuning in, no, looking at your answers, no. What will be our next step? Will we continue the statin despite the side effect? Tayo ba ay magmamalakas ang loob kasi may benefit daw, sabi ni Dr. Duya, statin pa more. No, letter B, stop the statin for 2 weeks. Tigil lang muna, no? Letter C, stop the statin indefinitely. Tansya-tansya natin, no? And letter D, stop the statin therapy for 6 weeks, no? Some answered A, continue the statin at a reduced dose. May nag-answer ng letter A pa din. So the first 3 answers are letter A. No, I'm still waiting for more answers. So all the answers are letter A. Sobra ko po yata kayong na-convince na mag-statin na kahit meron ng rhabdomyolysis, nagsa-statin pa po kayo. This is what I'm trying to say, no? Ang Filipino, madali po tayong maengganyo with good marketing skills, no? So, ang statin po, ito po yung red flag, no? Kapag meron ka pong muscle symptoms, no, muscle pains, no, muscle aches coupled with T-colored urine, and confirmed elevation in liver function test, and your elevated creatinine, then we should actually take a look at where this patient actually falls into, no? Sa myalgia, meron lang po tayong muscle ache, no? Symptomatic lang, no? May weakness, pero normal yung laboratory parameters. Myopathy or panghihina ng muscle, any disease of the muscle, meron tayong elevation ng muscle enzymes ng more than 10 times, no? Pag meron tayong muscle pain with creatinine kinase elevation, meron po tayong myositis. At may rhabdomyolysis or pagkamatay at pagputok ng muscles kung tayo ay may target organ damage na, such as kidney and liver failure or more than 50 times the upper normal limit. Ano dapat ang gagawin natin, no? So we stop, no? First and foremost, the dictum of medicine. May nakita na po ako, Ma'am Florge Ting, tama po kayo. We should stop the statin temporarily for 6 weeks. And then, after 6 weeks, try to repeat again the liver enzymes. Then we see the patient, we hydrate the patient, no? We remove all the hepatotoxic and the nephrotoxic medications, no? And see if the patient will improve, no? Ingat-ingat din po tayo. And that's the reason you really have to follow up to your doctors even if you are on statins. Statins are good, but given the correct dosage and the correct indication, it can prolong your life, it can prevent diseases, but it can also cause you harm if given overdosage or mali yung pagpili ng statin para sa iyo. If your creatinine kinase is more than 5 times elevated and if the patient has myalgia, you stop. Pero if less than 5 times elevated, tas wala namang target organ damage, you actually discuss about continuing it, kung magko-continuing nga, no, may rhabdomyolysis ka, magsa-stop ka definitely. You will go on a 6-week holiday. Ano po yung 6-week holiday? Hindi ibig sabihin ng 6 weeks holiday, yung 6 weeks pwede kang kumain ng kumain na parang nasa holiday ka. Ang ibig po niya sabihin, yung 6 weeks na yon, wala munang statin, ipapahinga ang liver, ipapahinga ang kidney, ipapahinga ang muscle until makarecover, and then you evaluate. Kung yung risk is persistent, no, hindi siya mataas siya, no, kailangan mo na siyang ibabang dose. Pag-uusapan niyo po yan with the patient, no. So for this patient, 45 times elevated, no, hindi niya ma-tolerate ang patient ang muscle pains. Yung pasyente merong signs ng liver and kidney failure, rather, no, pinag 6-week drug holiday mo siya. Pag ibabalik po natin siya, meron po tayong option. Either we combine it with ezetimibe, no, and low-dose statin, because ezetimibe makes your low-dose statin more effective by actually giving a synergistic effect. Para pong 1 plus 1 is not equals 2. When you add ezetimibe and a low-dose statin, like for example, no, simvastatin or atorvastatin, actually ang meron pong formulation na available ay ezetimibe plus simvastatin, no? Pero ito pong combination na to ay magiging 1 plus 1 equals 3. Mas malaki po yung benefit niya than the individual agents, no? Or you can actually opt to choose a low-dose rosuvastatin at an alternate day. Pwedeng MWF Sunday lang po siya or even weekly dosing lang of a statin. Okay? Next, this patient na-admit po siya, in-hydrate namin, yung statins niya, fenofibrate and simvastatin were withheld, and then after 3 days, nagno-normalize na po ang kidney function. Yay! No? This patient was discharged on amlodipine, aspirin, on your diabetic medications, no, on your statins and fibrates were withheld. No, what happened to this patient? This patient, again, after 8 weeks, kasi na-hold yung statin, came in unfortunately with a heart attack. This time, the patient, wala siyang choice. Heart attack na siya no? Nag-angiogram siya and we showed 2-vessel disease. However, wala siyang pera para magpa-angioplasty. So, the patient decided to go home, no, and just be on medications, no. This is the sad reality that we are facing day in, day out as cardiologists, no. No matter how much aggressive you want, no matter how good you are, if the patient's finances cannot afford them, then we have to rely on medications that may be that are not only cost efficient but also guideline directed and are also very effective. And one of them is statin. Why? Because statins are considered to be cheap compared to your other medications that are cardiovascular. No? So therefore, restarting this patient on statin is the next logical thing to do. But the problem is, what dose and what intensity of statin will you put this patient on? No? So, for this particular patient, no? Indeed, okay po. Ano po ang ibibigay nating dose? So, a lot of you answered letter C and D, but I'm still seeing letter A, no? Mamaya tatanungin natin bakit nag-A si Ma'am Laura at saka si Ma'am or Sir Boncuin, no? Atorvastatin 80 milligrams, no? Ano po ang tamang sagot dito, no? So, for any patient who actually have statin rhabdomyolysis or, no, babalikan po natin ito. Diba? So, this sa algorithm po natin, pag may target organ damage ka, magsa-stop po tayo ng statin. Therefore, you can actually start, logically, ezetimibe plus a low-dose statin, no? Or a low-dose rosuvastatin at an alternate dose of weekly dosing, because rosuvastatin is theoretically more favorable for the liver, no? And then ezetimibe will actually reduce the dose needed for your statin. And the statin may either be atorvastatin or rosuvastatin or simvastatin. But basically, the major premise is to reduce the the dosage or reduce the frequency, but still get the benefit effect of the statin. No, the main dictum is as long as your patient is on statin, there is some degree of vascular protection that is afforded to the patient. No, so how do you now actually restart? No, if there is less than 3 times elevated in the upper normal limits of your liver enzymes naman, no, continue with the statin. Pero you have to recheck kung meron pa siyang ibang sakit. Baka may hepatitis pala siya, may iba siyang gamot, antibiotics, naka-antifungal pala siya, no? Annual screening of your liver function test, no? Is still elevated but less than 3, resume the statin at a lower dose or start with another statin like fluvastatin, no? If it's more than 3 times the upper normal cutoff for your liver enzymes, you should stop the statin. And for patients at very high risk of CVD na hindi mo ma-forgo na wala kang some degree of protection, dito papasok yung non-statin therapy for LDL, such as your ezetimibe, your fish oils, your triglyceride, your fenofibrates, no, while off statins, and you recheck the ALT AST after 2 weeks, and then resume statin earliest kapag favorable na yung liver function test mo. Basically, you always have to try to re-challenge with a lower dose of statin and with a different metabolism, no? Para po itong X, no? Hindi porke ibig sabihin nag-away kayo ng jowa mo, ihiwalayan mo na siya. No? Because give them the benefit of the doubt. No, probably give them some time. Cool off muna tayo ng statin. Probably not 3 months but 2 months is enough. 6 to 8 weeks of rest. And then we re-evaluate. Parang naghiwalay, mag-isip-isip kung paano aayusin ang problema. And then, itry po natin ulit. Ang theme song ng statin, sa statin side effect, one more chance, no? So, baka there could be, one more chance or ano ba yung isa? A very special love the second time around, no? So, statin therapy in ACS has proven to actually reduce, no, the mortality short and long term if you start it as early within 5 days of onset. So very important, kung hindi mo man siya na-start on day 1, no, within 5 days dapat masa-start mo siya. No, saan naman ngayon yung fatty acid? Since the 2015 guidelines, paulit-ulit na po itong lumalabas. And until now, same pa rin po yung guideline recommendation that is not recommended as an alternative to statins for secondary prevention. But it can be an add-on for those patients who are not tolerating statin and who have low HDL cholesterol or who have high triglycerides, no? Doon po papasok ang paggamit ng omega-3 fatty acids. So if in general, if you're going to look at the non-statin therapy, fibrates will decrease your LDL by 20% at best, triglyceride 20 to 50%, and the change in HDL cholesterol is about this size, no? Hindi po siya consistently strong. Nagbabari-vary po siya, depende po sa mga studies. But ezetimabe's decrease in your LDL is consistently about 18% on top of your statin, with a minor increase in your HDL and a minor decrease in your triglyceride. Evidence for ACS in statin, maliliit po. 110 patients treated, 1 mortality prevented. 125 treated, 1 death prevented. 227% treated, 1 stroke prevented. But for major CV events, composite, 43 treated, 1 major death actually prevented. This patient was lost to follow-up after 3 years. The patient is now edematous, dyspneic with a creatinine of more than 900. Nag-fail na po ang kidney kasi medyo pasaway si mother, no? During hemodialysis, the patient developed heart attack. And then, the doctor, the cardiologist, hindi po ako to, this is a theoretical case, underwent emergency PCI for the ST elevation heart attack. No? So, this patient, among patients with CKD, who are on dialysis or not on dialysis, should be given statin to reduce the CV risk. And among CKD who are not on dialysis, the use of statins will reduce your CVD risk. Ano po ang sinasabi ng 2020 guideline? This is new in the guideline because in the 2015, wala pong portion on those na nagda-dialysis at may sakit sa bato. Ang kidney dysfunction po ay isang sakit na kung saan hinahalin tulad na po siya sa isang pasyenteng merong atake sa puso. Kung saan merong pagkakaiba-iba na ng the way natin tinutunaw yung mga taba. No? Usually po, ang mga pasyenteng merong dialysis or sakit sa bato, mabababa ang good cholesterol, matataas ang triglyceride, at matataas yung lipoprotein little a, which is another form of bad cholesterol. Peritoneal dialysis po, ito po yung dialysis na ginagamit ang tiyan bilang filtering agent, no, ay nagpataas ng ating bad cholesterol because of the constant exposure to dextrose, no. Makikita natin, no, evidence is high sa pag-start po ng statin for those with chronic kidney disease, no. Bago po ito, no, number needed to treat 18 per 1,000, no. Ganun kadami, no, 18 fewer deaths in 1,000, 13 fewer deaths in 1,000, 13 fatal and non-fatal heart attacks, no, and 7 fewer strokes in 1,000 patients. So yung dating sinasabi na may sakit ako sa bato, wag na po akong mag-statin, baka lalong masira yung bato ko. Hindi po. These studies have shown that it's still safe to continue as long as hindi pa nagdadialysis yung pasyente. And for cardiovascular events and revascularization, at a certain degree, no, 44 per 1,000 events are prevented by statin. So in general, kapag ang isang pasyente ay mahina ang bato pero hindi pa nagdadialysis, may benefit pa po ang ating statins, no? What does the guideline says? You have a baseline cholesterol, you have to monitor the lipid profile, and you have to correct the other risk factors so that you can reduce the overall risk. No, moderate intensity statins should be used. Never use a high intensity statin for a CKD because the moderate intensity statins will have a prolonged clearance. They can already act as if high intensity statins. No, so the combination of a statin and ezetimibe comes from the SHARP trial, which is a trial on CKD, has showed improvement in CV outcomes in patients with CKD or chronic kidney disease pero hindi pa nagda-dialysis. Okay? In patients with kidney transplant, ganun din po. Based on the ALERT triad, it's fluvastatin that can be used in order to prevent CV event. There is no recommendation to stop even if they're after the kidney transplant because the more na dapat natin silang protektahan kasi sayang naman yung ating investment for kidney transplant if we do not protect them. Finally, I'm at the end of my talk. The main take-home points are the LDL is the culprit, no? Is one of the mainstays and we should actually be after the LDL. So basically, the LDL for very high risk should be less than 55. For high risk should be less than 70. For intermediate risk should be less than 130, no? The triglyceride should be less than 150. The total cholesterol should be less than 200. The HDL for males will be more than 40 and the HDL for females will be more than 50, no? Statin first among any other. So I hope, no, after this talk, you will be able to be more confident, no, in serving your patients with statin therapy. Because of the time limitation, I decided to focus lang on dong requested niyo na topic na lipids because it has been very puzzling. But if you have further questions on diabetes and for hypertension, I have other lectures on it. Just look at the Ask Dr. Hart page for my previous lectures, and I hope I was able to summarize the findings of these guidelines in a nutshell in a little over an hour. So thank you very much po, and I'd like to end sharing my slide at this point. No, back to you, Sir Jay.
Alright, so for those of you who just came in, you are now watching the Galing ng Everyone Facebook page, which is in partnership with Farmacia ni Doc Incorporated. Once again, thank you to our speaker, Dr. Jose Eduardo Joey Duya, for sharing your knowledge and time to spread these wonderful lectures entitled Sugar, Fats, and Everything Not Nice. The Metabolic Syndrome and its Complications Unlocked. Dr. Napaka-siksik, napakabusog po ng lecture nyo for this afternoon. It's all worth it, no? Ang makinig sa'yo from start to finish. And I think, Doctor, due to your to your lecture na napaka-siksik ay yung questions natin. Parang konti lang yung nagtanong kasi very precise and very worth listening to yung lecture mo, Doctor. Anyways, Doctor, meron akong nag-gather dito coming from Facebook page, coming from Miss Maureen Albania Gira. So, question for Doctor, is it true na yung panganay ang at risk kapag nasa lahi po ang heart problem at diabetes? So, is it true, Doctor, or is it a myth?
Aray ko naman ma'am, panganay po ako. So ibig ba sabihin at risk? The risk is equal for all. Genetic risk po bang pinag-uusapan natin? Depende po, no, if we're talking about certain diseases like autosomal dominant, no, if you inherited that chromosome, then you're all at risk, no? Pero pag autosomal recessive, no, yung parent, may chances po na hindi equal yung inheritance ng risk. Pero no, wala na po tayong magagawa doon sa na-inherit mo ng risk. Hindi po yan tulad ng mana ng lupa na pag-aawayan pa. Ito yung mana na ayaw mong matanggap no? Ang magagawa na lang natin is paliitin yung chances na mag-manifest yung sakit by actually modifying or babaguhin natin yung mga condition na meron tayong control, such as yung ating intake ng sugars and fats, no? Yung ating physical activity, no? Yung ating lifestyle, no? Kung magsusmoke ka or mag-alcohol ka or illicit drug use ka, choice mo yon. Yun pwede mong gawin. Of course, you cannot change your apelido, you cannot change your family background, your genetic line, but you can always improve your outcomes in the future by changing the things that you can change. Sabi nga nila, learn to accept the things that you cannot change, but change the things that you can change for the better.
Correct. Thank you, Doc. Doc, dyan papasok yung modifiable na mga risk factors, no?
Yes, sir.
Pwede natin baguhin. Like mga vices.
Dyan po papasok din, sorry sir, dyan po papasok din yung mga drugs na pwede tayong makatulong for primary prevention. And it has become clear which are these agents na talagang makakatulong sa atin. Tested na po through long trials, no, that have been done decades ago, na hanggang ngayon meron siyang legacy effect, no, nagiging sustainable yung reduction in cardiovascular mortality if we continue them.
Alright, so thank you, Doctor. Doc, another question from Anonymous. Automatic daw ba, Doctor, kapag ikaw ay may diabetes, magkakameron ka na rin ng mataas na cholesterol at saka elevated blood pressure?
If you will have controlled blood pressure and controlled sugars, the chances are you are living a healthy diet, no? And if you are living a healthy diet, yung chances na tataas yung cholesterol mo, kung tataas man siya, is actually not that high, no? Mas controllable or manageable. We have patients that are on diet control. Meaning to say, we have patients who come into our clinic, mga young, relatively healthy pa, wala pang target organ damage. We give them a leeway of 3 months, no? Kung saan na ma-manage nila ng diet lang yung kanilang cholesterols, blood sugars, and blood pressure without actually having to take the long-term medication, so yung tinatawag nating maintenance. Pinipili po natin kung sino yung magbe-benefit ng kailangan ng mag-maintain at hindi. Pero there's always a chance, no? Yung trial period na tinatawag, no? Ang tawag ay balik loob sa mabuti at saka healthy lifestyle. Pwedeng-pwede po natin gawin yan, no? Pero kung automatic ba, kung hindi mo ipe-prevent yung pagtaas ng sugar mo at pagtaas ng blood pressure mo, talagang tataas po ang cholesterol mo. Kasi po, yun pong unmetabolized na carbohydrate will become free fatty acid at yung free fatty acid will become triglyceride, no? So, interrelated po sila kung nakikita ninyo doon sa ating mga diagrams.
Alright, so thank you. Doc, it's more of for clarification lang coming from Miss Hafsa, PPM Makadadaya. So can we give Rosu and Ator high intensity at the same time po? If yes, in what indications po? So 2 statin in 1, Doctor.
I have yet to see someone who actually started 2 high-intensity statin at the same time, no? Para mong pinagsama si Piolo Pascual at si Coco Martin sa isang pelikula, or para mong maganda lang siyang panoorin pero baka magrambulan sila, 'di ba, sa acting, or para mong pinagsama si Fernando Po Jr. at saka sino ba bang ang action star ng kanyang panahon. But my point is there's no point of actually mixing it, no? Because sabi ko nga natin, if you put in 2 high intensity statin, no, with the same mechanism of action, you probably does not double the effect. You just increase it at most by 7%, no less than 10%, but you actually increase the risk of getting a statin myopathy and a liver failure, no, or even a kidney failure if you do that, no. So if you are actually not on target, for example, for familial hypercholesterolemia, there are other agents that are more potent, no. We have now the PCSK9, no, which is actually a molecular blocker, no. So unfortunately, because of the pandemic, the PCSK9 molecule that is supposed to be launched in the Philippines this year has not been launched. But we are seeing that for patients with LDL that are more than 200, 300, 400, they actually respond. But they are injectables, no, and they're not yet available in the Philippines. But just in case, there are already available agents like that. But for the meantime, we can actually use ezetimibe on top of the statins, no? Pero if you have patients like that, please feel free to refer to cardiologists because we have access to those medications and we can actually refer them to formally trained lipidologists to help us access these medications for our patients.
All right. So thank you, Dr. Joey. As much as we want to entertain all the questions, lalo na ngayon, Doctor, maraming nag-a-arise sa Facebook page natin. But,
dami-dami, sir. Nakakatuwa po.
correct. But due to the interest of time, we really apologize. So next time, we'll ensure po na extend natin yung ating session with Dr. Joey Tuya. So once again, Dr. Joey, thank you for your lecture, for sharing your knowledge with us. You can now take your break for a time, and then I'll see you later.
Okay, sir. Bye, guys.
All right. Thank you, Doctor.
Thank you.
So now, gusto namin kayong imbitehan muli ngayong darating na Huwebes, November 26 sa ganap na alas 6 ng gabi magkakameron po muli tayo ng kwentuhan dito sa Galing ng Everyone sa usaping tatalakay sa pinggang Pinoy at ehersisyo. With our speaker, of course, Dr. Sherwin de la Cruz, our moderator, Dr. Alin Pasio, and our fitness coaches, Coach Jim and Coach Tony Saret. There you have it, everyone. Thank you for tuning in, and we hope to see you in our upcoming events. If you are in us today, please subscribe to our FB page. Hit that like button and share it naman sa mga family and friends natin. So once again, I am Jay, your host, saying, pangalagaan ng sarili, kumain ng tamang pagkain at umiwas sa mga bisyo dahil ang galing ng one ay galing ng everyone. Thank you so much.
Ikaw ang tanging kayamanan at pag-asa ng ating bayan. Sa ning larangan nakikilala, hinahangaan ng buong mundo. Hayaang umusbong at hayaang umaya, lumipad at sumama sa tagumpay. Ang galing ng everyone, ang galing ng everyone. Kaya ko, kaya mo, ang bawat pagsubok, lugod tayo.